understanding their symptoms. So is the patient nuts, or are we missing something because we all classify them as being crazy?
One of those captivating intros ever.
My music wasn't working perfectly that time.
Now it is.
And it's not even the correct song. It's all a discombobulated mess here. We're taking all your equipment, resetting up. I like to call it the snake pit.
Well, this is an exciting edition of Dentist on Demand, our podcast, because we're coming at you live from Ocean Ceramics Dental Lab in beautiful British Columbia, just outside Vancouver.
And who is this shiny guy we got in between us here?
It's not Elvis, right?
It is.
Maybe this is in
Elvis
tribute.
has left the building.
Maybe this is in tribute to the Elvis movie that's going to win Academy Awards. Is that what this is?
It's all about being a star somehow.
Yeah.
Okay, so I want to talk a little bit about Ocean Ceramics. So here we are. We've got James Neuber with us on the show, one of the owners of Ocean Ceramics here in just outside of Vancouver, British Columbia.
And also president of the DTA BC, which is
Dental Technician Association of British Columbia.
There you go. Yeah,
it's
a big deal. He's got a lot of letters in front of his.
He's got some
Complaints.
Yeah, that's right.
Did you say complaints?
Complaints.
Yeah. But either way.
So a quick shout out to Ocean is Vancouver's premium dental laboratory. For over 45 years, Ocean Ceramics has been providing high quality dental prosthetics to our clients around Vancouver, British Columbia. The creation of our sister entities, Dentafor. Can you see Dentafor behind me? Is there a...
Maybe if I hit a different camera angle here. It's behind
it's
your...
on the front of the skull.
It's behind... Oh, it is.
Right here.
Just wait for the skull to turn around. But it's behind your melon, actually.
So education is a huge part of what they do here at Ocean Ceramics. With Dentafor, which we'll get into, and Trio Creations. It has allowed us to become a full-service dental laboratory that they have become today. Learn more about Ocean Ceramics Company history and our team, what our clients have to say about us. And I'm reading that right from the website because there's a little action here that says "Learn more."
Yeah, exactly.
Beautiful website,
and just like a fantastic place to be, family-owned place. They care about their work. I can't say better things about Ocean Ceramics. They're running around here on the phone with doctors with articulators in their hands. Like it's a really hands-on experience.
it's a really cool environment here for sure. So welcome, James.
Welcome.
Thanks, guys. Thanks for having us and hosting here. It's just always a great honor to have good reach into the dental community through your network. So whatever we get to share and teach people tonight is always a great joy because we're all about education.
Awesome. Yeah.
Very cool. Because we've got a second component to this. We not only have James, but we have Dr. Dennis Marangos of the Yorkville TMJ Center also joining us today. Shall we do the reveal? There he is.
There
Do we have an audience clap for him?
Oh, hang on. How about this? You couldn't really
There
hear
we
it.
go. That's good.
Here.
There it is.
A little bit.
I
That's
love
more
it.
exciting. Yeah.
I love it.
Joining us from Yorksville
Yorkville.
in the practice today, Dennis.
Yeah, well, I'm actually in my GP practice today, which is just outside. Yorkville is where my TMJ and sleep practice is, and I have a general practice just a little east of that, in an old part of Toronto.
What team do you like better, your GP team or your? I'm just kidding. We won't.
Yeah, well, I can't say that. I'm gonna. If you're talking teams, I'm going with the Leafs.
Okay, that's been the end
All
of
right.
this discussion.
You're in Canuck country over here, so
Well, it's time to cut them off.
Yeah, well, we got a Boston fella between us
I
here.
know.
yeah, we got two originals here. So
So let's.
Put my man Marchand right here against my coffee cup.
Oh
here.
no! Yeah.
okay, that's it for me. I'm out. Bye.
So let's start out to talk about the connection. So James, Dennis, I'll let you guys kind of take it away. So, what's the relationship in between what you're doing, Dennis, your specialty, and Ocean Ceramics?
You know, I'm going to take point on this one, you guys, because I want to tell a quick story about how my brother and I, and we've been partners in the dental lab for decades, and we always had this quest of how do we do full mouth rehabs, arches, the best way? Because at the time when we started in dentistry, really a lot of general dentists were just kind of fumbling their way into hopefully they were getting the bite right and hopefully the cosmetics would be right. So Dave and I went on this journey of searching for mentors who could teach us how to do full mouth rehabs properly, predictably, without any adjustments. And so through our journey of education, we eventually came along with Dr. Marangos and Dr. Liam. We formed Denta4, and Denta4 is about how to optimize a patient's function with airway, jaw joint, muscle, and then the teeth. And so this is really, I'll just diverse to you, Dennis, how you fit into that whole picture.
Yeah, and you know, getting away from, I'll tee this one up for you. Getting away from single tooth dentistry. Elaborate on that.
Well, here's the general progression for most dentists. You graduate from dental school. You're given. They tell you got 5 to 7 years to get yourself comfortable in dentistry, but all you know is what they taught you in school. You see a broken tooth, you fix it. You see another broken tooth, you fix it. Nobody talks to you about why the teeth are breaking. So it took me about 7 years to figure this out. And then I was very fortunate that I came across a couple of different groups, everybody from, especially John Coyce out in Seattle, where he was the first one to kind of open my eyes and put it all together. Up until then, I was studying at the American Academy of Cosmetic Dentistry. I took a cosmetic dentistry residency at University of Buffalo, but there was still something missing. It was just not coming all together until I started to learn that the joint had something to do with this. So I've had a TMD sleep practice for almost 25 years plus, not knowing fully the relationship between TMD, ortho, occlusion, regular general dentistry. And so the concept of the single tooth dentist is essentially what they teach in school. You come out of school, you know patients have insurance, you work to their insurance. They don't value what you're doing for them because you're only fixing what's broken. And then ultimately you're waiting for the next problem. So I got tired. I got tired of that. It was very frustrating to constantly be repairing broken things. And then finally I came up with my amalgamation of different programs where I studied to come up with my system that is a combination of all the giants before me. So it's not anything I invented, but going back to that single tooth dentist idea, it's where most dentists coming out of school and for the first 10 years of their practice, that's where they swim. They hang out there, they're getting tired of it, and ultimately they find somebody that talks something different, and they're going, I get it. Now I see it. Where do I go for more information? Well, Denta4 was a very neat union that we formed, where Edmund talks about the TMD and sleep component, and then I do the restorative component, bringing TMD, sleep, occlusion, adhesive dentistry, dental materials, and we bring it all together so that you can start your journey on becoming a complete care dentist. So, sorry, go ahead.
I was going to ask Dennis. So, like, the overall sentiment out there, like, is there generally a fear for dentists to get into the TMD world and occlusion?
And I got a question too. So, tell me the difference between TMD and TMJ. Like, what, as a layman?
Okay, so TMJ is the temporomandibular joint. It's the anatomical structure. Temporomandibular joint dysfunction, TMD, is the dysfunction. It's actually the disease process that's involved that encompasses the joint. But it's more than just the joint. It's muscles, it's nerves, it's teeth. It's how they all interact and what breaks down because of something else. Peter Dawson, for those of you who I had the pleasure many years ago in my journey to listen to this gentleman speak, and he was one of the first ones that identified to me the concept of complete care dentistry. And his textbook is one of the ones that changed the way I looked at things, and then started the rest of my process. But he takes it all the way back to, if the general dentist doesn't know anything about the joint, you are doomed to repeat your failures. So the teeth, which we all focus on, are the victims of poor joint, poor muscle, poor neurology, and all that function, and then teeth start breaking down. So most of the patients I see is they don't have healthy joints, but we make the joints healthy, which allows us to then restore them in whatever method that we need. So TMD is the disease process. TMJ is the anatomical process. So the equivalent is, if an orthopedic doctor comes up to you and says, Mark, you've got knee. So,
Right.
yeah, I got two knees, right? And,
Right.
tell me more about what my knee is doing. Well, it could be a ligament, it could be cartilage, it could be osteoarthritis, or a combination of everything. So, when patients say, I have TMJ, I say, yes, you have two of them. One's here and one's there.
Right.
Right.
So a little tongue-in-cheek answer, but if you go back to the philosophy of Peter Dawson and some of the other academies out there, like Pankey and like Coyce and Spears, they all focus on the joint being part of the occlusal problem or the occlusal solution.
Right. So essentially, you're not selling the procedure itself. You're wanting to sell a solution for a patient.
Well, yeah, that's an interesting point, because I don't know where everybody is from, but in Toronto, like if I just walked out of my office here, stood on my porch of my office, I could probably count about 20 dentists. Okay,
Wow.
so that's just it, like visually, and I could
Yeah.
just point around, and there's at least 20 dentists. Everybody's got a different practice. So the part of the problem here is that dentists are in many cases aren't very confident. They'll say, for example, I'll say, Tyler, you need a crown, and the price for your crown is dollars.
Right.
And then you sit there, and the typical response is, okay, you know what? I can reduce that. I'll give you 20% off. And you sit there. If you sit there long enough and don't say anything, the dentist is going to give it to you for free.
Yeah. Just keep my mouth shut.
So there was an article that I found a couple of years ago. It was called "The Amazon Effect on Dentistry," where patients look at dentists as a commodity. So when they see an implant, they see the parts. They see an IKEA tooth coming at them because you pull out these IKEA tools to put their tooth together. So some dentists look at patients as a consumer, not as a patient. So when you look at the Amazon effect, what that leads dentists in general to do, it's a race to the bottom.
Mm-hmm.
It's a race to the cheapest price for the patient, and nobody wins in that scenario. So when you go back to that crown scenario, what dentists typically, the way they present a crown to a patient is they'll turn around and they'll say, Tyler, Mark, you need a crown, and what we're going to do is take 0.5 millimeter or 1.5 millimeters off your tooth, take an impression, do what we need to do. You're going to come back in 2 weeks. We give you more freezing. We take the crown off and we put in your permanent crown. You've just scared that patient.
Right.
Because what they want to hear is not that. They want to hear, what is the crown going to do for me?
Mm-hmm.
So if I said to you, Tyler, Mark, we're going to talk about getting you a crown. What that crown's going to do for you is protect your tooth from further breakage and damage. because the last thing you need is to continually show up on my office with an emergency, because it's costing you time from work, time from your pleasures, and it's giving you pain, and you're aggravated, and you just get very disappointed. But if I give you a solution so that you don't face any of those problems, are you okay with the crown? Who doesn't want that? The patients will say yes. And if you noticed in that conversation, I didn't once tell them how much I'm going to remove their tooth. You mean you're going to drill my tooth down to a peg? That's what patients hear. But if I say to you, I'm going to give you something that's going to protect your tooth from further breakage, you're all in.
Fully.
So that's kind of where dentists are selling procedures. They're not selling solutions. Patients want a solution to a problem. They don't necessarily need to know the procedure.
So speaking to your colleagues, where's the fear that, like, what's stopping a GP practice from selling solutions and doing, carrying out this philosophy? Where's the break there? What is it what they're taught? Is it just purely lack of knowledge?
Educational.
I just want to chime in on one comment, Mark.
Yeah.
I think a key word a fear that we hear a lot of dentists say is they think they have a fear of selling. Mm-hmm. I always say, you know what, your treatment planning, the patient's engaging in a decision to follow through with your treatment plan options, and they have a fear of thinking they're salesmen. It's like, no, like some people, if you go back to the knee, they might need a half knee replacement when but you decide when you're ready. We're here to help you when we are.
Right.
And that's not selling. And a lot of doctors we hear, they think, oh, I don't want to sell.
Yeah.
That's what we hear.
But like, is there a fear to get to talk about TMD, to talk about airway
and occlusion?
Is there a lack of confidence to talk about these things?
Generally speaking.
Yes, absolutely there is, because in school, we were taught really nothing about TMD in school. I started learning about these patients who are chronic pain patients when I did my hospital residency in '86 and '87, and at that point it was a very generic kind of program where everybody got flat plane splints, and they got a list of medications, and some got better, some got worse, some got no different. And then my evolution introduced me to different practitioners and different concepts of how to treat these patients. So in school, you're not taught anything about case presentation. But I don't know which one of you said something about treatment planning. That is the key.
James.
Yeah.
Right.
The key is sitting down, and in my practice, we have 2 levels of exams. We have a level 1 exam, which is what you would consider your general dentistry examination and findings. So what I do is we take a full set of x-rays, we take photographs, we do different tests, and then I sit down and I have a face-to-face conversation with the patient about what we found. I never present a treatment plan at that appointment, because many times the patients turn around and say to me, you know what, I've never had this type of discussion or examination with my dentist. So then I say, well, what I'm going to do now is I'm going to sit back, I'm going to look at all our data, and then we're going to come up with a treatment plan, and I present it at their next visit. And that goes over so well with patients, and our case acceptance levels are like off the charts.
It must build a lot of trust too with that process, Dennis.
Yeah, it's
absolutely.
If we're talking it in terms of a plan to solve, a long-term, provide a long-term solution, rather than just like a quick little fix. Like, it's all about
that's right.
The why. Like, why is this happening? Like, let's stop the problem.
You got it.
Underlying first before we just fire up the high speed, right?
That's right. So in many of the cases that I show during our programs, our patient, you see the doctors sitting in the around the table, and they're nodding their heads because they know that all those patients are in their practice. So when I turn around, and it was I think it was Gordon Christensen who said many years ago, if you have about 1,200 patients in your general practice and you're doing comprehensive dentistry, you do not need a new patient in your practice to finish your career. If you're identifying those needs in those patients. So imagine if all of a sudden you're identifying TMD patients, sleep patients, and they turn into restorative and full mouth rehab or ortho patients. You're going to be working for a long time. And the beauty of that is these patients already trust you. They're in your practice.
So,
So when you go ahead.
what's this is amazing. So what's the relationship then? So like in between TMD and airway and sleep, like how do all of these pieces link up?
So here's the dilemma. I hear this all the time when I'm talking. Doctors will say, "I don't want a TMD practice. I don't want to treat all these crazy
Right.
people
We
because
hear that all the time. Yeah.
everybody says TMD patients are nuts." Okay,
Yeah.
and my answer is I've got two answers to that. Well, first of all, can you imagine being in pain constantly, all day long, all night long, every single day of the week? You can't eat. Drinking is no fun. You just can't. You're popping Advil vitamins all day long. Wouldn't that drive you nuts?
Yeah.
Sure. If you pulled your back muscle shoveling snow, that little bit of pain drives you nuts. Forget having pain in the head, where our nervous system, Mother Nature designed us with the highest density of nerves in this area. So a headache can be debilitating for these patients. So the second answer, if you look at the word nuts, it stands for not understanding their symptoms. So is the patient nuts, or are we missing something because we all classify them as being crazy? They're
And
not.
and
They're just in pain.
there's a like a Facebook group.
I'm on that one.
Yeah, and I think it has close to 200,000 people on it, and it's just a constant stream
People begging for help.
for help. Like,
Yep.
Where do I go? What
Yeah.
about this guy?
Yeah.
Have you heard about this? I've referred tons of people, just trying to refer them to like maybe a dentist that's involved with the AACP, because they'll go, "Oh, I live in Texas. Who can I go see?" And many times I say, "Go onto the AACP website," and a lot of times there's member dentists who are specialized in treating your types of symptoms. So that's where I would go, because what we see, Dennis, is a lot of people think they know how to treat TMD, but a lot of them are lost and they're guessing with their treatment.
So my question off
Well,
of that, sorry, go ahead, Dennis.
Yep. Oh, no, you go ahead. Go ahead.
Well, my question coming out of that now, is there a relationship between these disorders and general dentistry? So is there a way to
Yeah,
bridge that
sure.
gap?
Sure. So let's take one step back. So when you asked about the fear of dentists, and it's a fear because they don't understand. So there's a fable out there called The Five Blind Men and the Elephant. And you take these five blind men and you put an elephant in front of them, and each one finds something different. It must be a wall, it must be a tree, it must be a snake, it must be something else. And when you take the blindfold off, what do you have? You have an elephant. They're all looking at the same thing, but their interpretation is very different. So occlusion, TMD, sleep is the elephant. All the blind people around there are the dentists who are looking at just one small part of that process. If you open your eyes and you see the elephant, you're going to go, wow, now I get it. Now I see what I'm looking at. So there was studies back a while ago where they were looking at the population in a general practice of how many people have sleep disordered breathing. So in a general practice, it's about 33% of men and 7% of women. So in general, the prevalence of sleep apnea in the general population is over 17% of men and 9% of women. But in your practice, because the reason the practice numbers are higher is because you have a group of patients who come to a healthcare provider at least twice a year. A lot of people don't go to their family doctor unless they have a problem.
Right.
So as dentists, we see our patients twice a year minimum. So if you have 33% of men, 7% of women in a general practice that have a component of sleep disordered breathing, that's 40% of the patients in your practice.
Right.
That if you identify them, and it's so easy to identify them when we talk about the risk factors that we can see. Imagine if you're worried about income, imagine the cash flow that you just created by starting to treat those sleep patients. Well, I got news for you as well. In another study, there's a relationship between TMD patients and sleep. So now it's called the OPERA study, had connected these two disease processes very intimately, and you can't treat one without knowing the other. So now you've just boosted your practice. So, and you're helping patients. Forget about the kids in your practice, because pediatric sleep apnea is off the charts these days. Off the charts.
Like Tyler and I, we are a dental marketing company, and
Platform.
Growth
Dental growth platform.
Growth platform. It's always
We're
evolving.
not a marketing company.
But this is like a definite aha for me. One thing that I preach with all of our clients is, let's take a look at your dental business. Let's take a look at your patient base. What opportunities are you missing that are already in your door? And everybody's all about, I need new patients. I need new patients. I need new patients. When the hugest opportunities, I think, are helping your existing patient base.
And I think a refreshing take on that,
Go, Tyler.
The take on that I think is refreshing for the people we work with is like, wait a minute, you guys are marketers and you're telling us not to market to new patients? We're like, there's a gold mine in your practice. Let's start with that first.
Let's start with your people first.
Sorry, go ahead, James.
So, and you know why that's important? Because you've already created the trust of those patients. A new patient takes so long for them to trust you and to allow you to do something. Right. So if you're doing comprehensive dentistry, so here's what I did in my practice. I'm a graduate from 1986. So I don't see new patients anymore. I only see patients if an existing patient has a family member that they want to refer to me, I see them. My TMD practice, I see new patients there, but in my general practice, I don't see new patients. But when I did see new patients, I used to see them on Tuesdays and Thursdays at 8:30 and 2. I only saw 4 new patients a week. Now, why would I see them at 8:30 and 2?
I'm drawing blanks. I'm trying to be smart.
I'm thinking why I would do it is that's when my brain is the most fresh and creative. In the morning. In the afternoon, that's usually when my brain resets itself. That's personally that's the thought that comes to my mind.
That's a small part of it. One of the things that patients hate to do? Wait.
Yes. Wait.
How would you, as a new patient at 8:30, first patient in the morning, 2 o'clock, first patient after lunch?
After lunch, right. There you go.
I'm waiting for them. When they walk into my operatory, I'm already there to greet them. I'm on time.
Oh, that's smart.
Mm-hmm.
Yeah.
How much better to create a good impression for a patient that you don't have to wait? And the name of a waiting room, like that's awful, because you're going to be waiting.
Yeah.
It should be a reception area.
There are fewer worse places on earth than a reception area in either a medical or a dental clinic.
I have never seen or heard of one medical office being on time with their appointments in my lifetime.
No.
Oh, yeah. No.
They're always late.
Especially your GP, like doctor.
And that was before the days of Facebook and cell phone, where you could just get lost in your phone in the waiting room.
You have to read a Chatelaine magazine
Yeah.
Oh, I know.
That's
So
3 years
magazine
old.
is a
It's
year
3 years
old.
It's not a year old. It's like
It's a 3
5 years old.
That's
Yeah.
right.
Yeah.
Dr. Raymond said that.
Yeah.
Yeah. So they there's two caveats to that. Beware of dentists and doctors whose plants are dying in the waiting room and have old magazines. You don't want to go to those doctors. Right?
Hey, Dennis, don't forget the
Yeah.
fish tanks too.
The fish tank.
Yeah.
Run.
The fish tank.
The fish
Absolutely,
tanks.
Absolutely. Yes. So yeah.
Um,
So anyway, so I would only see 4 new patients a week.
Yeah.
Okay, and that was it. But because I did the examination and we did comprehensive care, that drove my practice. And that was just our philosophy and that was our setup. And to this day, I still prefer to see my new patients, the few that I see, at 8:30 and 2.
So Dennis, where did you start? Where did you get your education on all this TMD, restorative sleep? Where did you start, and where is it now? Whereabouts are
You
you?
did mention
in it all now?
COIS, but is that where it started?
No, actually, all of this started when I started doing orthodontics in 1987. And I was very fortunate to be introduced to a fellow, Brock Rondeau, and the IAO, the International Association for Orthodontics. And through that connection, I learned about TMD and that, the orthopedics behind orthodontics, because I did orthodontics up until a few years ago, and we were doing full bracket cases, everything. Then, based on that, it taught me or it led me to a cosmetic practice where I was going to the American Academy of Cosmetic Dentistry meetings. I did the program at the University of Buffalo. But in amongst all of that, with John Coyce as well, I took programs with Paul Homily. I took programs with Walter Haley and his dental boot camp. And those ones were very unique programs in that they taught you how to communicate to your patients and with your patients, and how to do a case presentation so that you can answer patients' complaints and concerns in a non-threatening way, and you had an open dialogue that went back and forth, and it was just a beautiful synergy that took me years to put together into my system. But I didn't invent any of it. It's just that I was able to take pieces from everybody I learned from. Then about 20 years ago, I was introduced to the AACP, the American Academy of Craniofacial Pain. And that was where the aha moment came for TMD, where you met the some of the gurus, the Harold Gelbs, who's the Gelb appliance is named after, the Brendan Stacks. There's so many giants in that academy that gave their time so freely and so willingly to educate us, and it was just one of the best finds I made. And then that allowed me, with whatever I had in the background, to bring it together to develop what you may want to call it my system. So I spent more time in classrooms and on airplanes learning, flying here and flying there to learn this stuff. And the academy is still going, and it's still a great academy. I was the founding president of the Canadian chapter of the AACP back in 2006, where doing TMD treatment in that sense was a very frightening experience, because many of the colleges across Canada did not like the type of treatment that was being offered, which was essentially a dental appliance to reposition the mandible in a situation that took the pain and pressure off the joints. And there were so many misconceptions about that, but through the AACP, we were able to change that. And that's where the beauty of all this is. And our Canadian chapter is we're just kind of floating around. We're still around. We're still doing stuff, but the pandemic didn't help us in terms of live meetings. That hurt us a bit, but we're starting to get the ball rolling again. And the chapter still has some dedicated members that we're gonna do it. We're gonna bring it back. and get these live programs going. And I know that at some point during this chat that we're having, we're going to talk about our program with the Denta 4 program that's going to help introduce people to that, and that can, a lot of people can use that as their stepping stone to the next level.
You know, Dennis, one of the things that was really, really opened my eyes over the years that I learned about treating TMD is, and I explain this at dinner parties and friends all the time in a very simplistic way, is a lot of the pathology is because the joint is compressed, you know, and everybody can relate to when I show them this imagery where I go, if your condyle is compressed in the fossa, you're going to feel pain. And now, isn't it make sense, Mrs. Jones, that if we decompress the jaw joint, that you're going to feel some relief possibly in treatment? And that little word picture with my fist in my other hand has always opened up the eyes of hope to people that have been suffering. And then, of course, I go into, you know, explaining with a series of appliances that we can, you know, with proper examination and diagnosis, that a treatment plan can be developed for you. But a lot of people understand that if something's compressed, it can cause pain. And if we can decompress it strategically, that there's light at the end of the tunnel. And that's been a very, very generic explanation for patients.
But you have to keep it simple, and you know, you have to have diagrams. You have to show them. Like today, for example, this morning, this was one of those moments that you know you wish you recorded it. So so in my general practice, I still treat patients that have joint dysfunction because they're in my general practice. So I delivered 2 orthotics today, a day orthotic and a night orthotic. And the patient's looking at me, and I'm going, "What's wrong? Like, you know, are you okay?" She said, "You know, you put the appliance in, her day appliance," and she goes, she's biting. She goes, "Wow!" And I go, "What do you feel?" She takes it out, and she goes, "Ouch!" And she puts it back in, and she bites, and she goes, "I don't feel anything. There's no pain." She goes, "I have not felt no pain for a couple of years."
That's amazing.
And that's every time. Yeah, it was so cool. And people don't realize that they think it's all about chewing. Well, we swallow over 2,000 times a day. And if we have a normal swallow, our teeth come together. So try swallowing. Your teeth come together and the muscles act. Mm-hmm. Try to swallow now without bringing your teeth together.
It's
you have to think about it. It's awkward. It doesn't work, right? Yeah. So the people that can swallow without bringing their teeth together usually have other dysfunctional problems, which we go down a whole other myofunctional tongue. You know, there's other issues there that, you know, we will expand on during our programs. But we know that when we swallow, our teeth come together. Yeah. And you do that 2,000 times a day, you're going to have pain in your joint. And people think it's all about clenching and grinding. It is, but it's also function that gets in the way.
Right. So now that we've kind of come full circle here now, so you've kind of mentioned the Denta 4 course here, like a little bit. Let's like, obviously there's the philosophy behind all of this, and that is Denta 4. James and David and Ocean Ceramics is extremely passionate about this philosophy. This is the connection. Let's talk about that with folks. So, like, let's tell our colleagues, like, how do we get involved with this?
Yeah, I think the question was, how can, you know,
I'm fumbling around here.
Your general dentist.
I'll tell you why you're fumbling around, Mark.
What's that?
Because I heard a guy say once, there's some topics I don't like to talk about, and that's sex, religion, politics, and occlusion.
There you go.
So we'll let Dennis take that one.
Yeah, that's right.
Okay. So Mark, if you can pull up, I think I sent you a couple of slides. Let's look at slide number 29. If you can pop that up.
No problem.
Slide number 29 has 3 CBCT profiles. They're
Ah,
side
yeah.
views.
Oh, I see it. Here we go. Okay,
Okay.
just let me
Okay.
bear with me. I'm pretty fast. Fill the empty space here with some of your vast knowledge.
Okay.
Well, I get
So
this.
so what's happening here is earlier you asked about the general dentist, sleep, and restorative dentistry. Is there a connection? Well, there is, because in this case, I'm going to show you, and the slide right after it, if you have, there's two scenarios. You have a patient who you made a night guard for. It's an upper night guard, it's flat, which is what we're taught in dental school. You deliver the night guard, it fits perfectly. You would have scored a 10 out of 10 in dental school. Patient comes back 6 months later, you ask them, so how's your night guard? And they say, Doc, it fits beautifully, but I can't wear it. Well, what do you mean you can't wear it? Well, I'll put it in halfway through the night. I find in the morning, I must have taken it out because I find it under my pillow, under my bed, and I take it out. And you're sitting there going, well, you know what, got to be the patient because my appliance fit like a glove. James and David made me the best appliance. What that patient is telling you is that they are a hidden patient that has a sleep disorder breathing problem. Because if you've got your jaw sitting like this and you make a maxillary flat appliance, the patient lies down, their mandible drops back,
Choking.
they choke.
Yeah.
They are choking. So they take their appliance out in order to breathe. So now you have an understanding that patient, if you look at the whole elephant now, you understand that they have a potential sleep disorder breathing problem.
Mm-hmm.
Well, in the slide that you're seeing there, you have the first one on the far left is a patient that they have a current night guard. So these patients are sitting upright, they're vertical and awake. Look at how narrow that airway is with a maxillary flat plane appliance. The middle slide shows them in their MIP bite, which is just their natural
Centric?
bite. The air, if you want to call it centric, but that has a whole different misnomer, but I call it MIP.
Okay.
That's your maximum intercuspal position. That's
Okay.
this, okay? Their airway is still constricted. But if you look at the image on the far right, that is their airway with our construction bite for an appliance. You can actually, without knowing anything about the anatomy, visually you can see that the airway is larger. It's green. It's larger than the other two. And this is, again, in the upright awake position. So now we say, oh, okay, so now our dental night appliances aren't working, not because I didn't make it right, it's because we're treating the wrong thing.
Mm-hmm.
It's the wrong device to treat what the patient has. If you look at the next slide, slide number 30, it talks about it shows the two central incisors. So if you have a patient that is a subclinical sleep disorder breathing patient, and you build up either a single crown or a class 4 composite that has too much anatomy on the lingual surface, it can distalize the mandible and cause an airway collapse when they're sleeping. So when you're looking at these patients, why do your class 4 composites break? Well, it can't be you're using, lousy bonding agents or lousy composite. You do a good job. Most dentists are very good at doing that. But at night, what they're trying to do is the mandible is coming forward, trying to open that airway. And it puts pressure on that tooth, on that restoration. And what does the patient tell us the next day? I was eating something soft. I was eating a hot dog bun and my tooth broke.
Yeah, we see that all the time, Dennis.
The tooth was broken because of what you're doing at night, because we made that tooth too big on the lingual, causing the mandible to distalize. Then when they lie down at night and go to sleep, the mandible wants to come forward, and they keep banging into that tooth, and it's going to break. James, what's one of the things that you always ask your dentist for more of in the anterior?
Well,
Loaded
reduction
question.
on the opposing.
Or lingual reduction on the tooth.
But you know what I see further to that, Dennis, is one of the biggest problems that is overlooked. When I analyze, I would say when I'm checking a case and say we're doing a central, two centrals, a lateral, or whatever, a single tooth anterior restoration, most of the time the opposing lower dentition is orthodontically out of whack, crooked.
Right.
So there's like a labialized central, lower central. So I just know that is like a hammer on an anvil through the night, coming forward. And it's like a point force on the back of the tooth. Like you say, it's like bang, bang, bang. And it's, whereas if you have restorations that are orthodontically correct on the lower, now you have a normal protrusive, maybe if they're functioning at night or eating or so on. But when you have like a labialized central, we always have to dust off the enamel a little bit to create proper function so that the crown isn't stressed. But just imagine, well, I know that because I have a crooked lower central, but that there's always some sort of point force that's traumatizing an anterior tooth. And just about every anterior restoration we check, there's something orthodontically out of position on the lower. And I know it's just causing trauma to teeth on the top because of nighttime parafunction.
You know what you just described? The dilemma of the single-tooth dentist.
Exactly.
The goal of the single-tooth dentist is they want to place that single crown on the upper maxillary central incisor because that's what the insurance covers. And that's, you know, I need that money to pay my payment on my Tesla. Okay. As opposed to if I did the whole comprehensive dental treatment, I could buy Tesla, the company. Okay. Eventually, you see, it's a bigger picture. So the dilemma, so the solution to that problem is quite simple, is especially now with aligner therapy and orthodontics, you can do, and I do this quite often, you do pre-restorative aligner therapy to correct the problem you just talked about. Okay, so you put the teeth where they need to be. So if a patient says, well, I don't want orthodontics, and I've said many times, you may not want it, but you need it to accomplish what you want me to do for you. Mm-hmm. So if you don't want me to do that, then I can't help you because I know it's going to break. Because anybody listening here, if you've been practicing more than 5 minutes in dentistry, how many times have you seen a central incisor break off at the gum line?
Yeah.
And you're wondering, why did that break off? It's because of what you just described. It's the occlusal forces that we didn't see by focusing on the tooth. So we're not focusing on the elephant. So I'm back to the 5 blind men and the elephant. You look at the elephant, not just the stump of the leg thinking it's a tree stump or the tail thinking it's a snake. It's the big elephant. And in order to make our dentistry more successful and predictable, sometimes we have to say no to these treatments because we know it's going to fail.
Dennis, one of the biggest treatments that we don't say no to, but I really caution dentists against is the no prep veneer case because they just want to put the sexy veneers on the front, no prep, stick it on there. You have teeth like Mr. Ed, but the function is you just know it's destined to fail because even though you put these fancy veneers on there and there's no shot and all the advertising that goes with it, I just know that function can never be corrected or to facilitate the new smile unless you look at all the other comprehensive stuff you're talking about.
So Tyler and I are doing a video piece for, we won't say any names, but a video piece on a veneer case that is experiencing just that. He's correcting.
He's trying to correct it,
correct a case. So anyways.
Yeah, so ultimately, you know, all of this boils down to that initial exam, making a diagnosis, finding out what are the problems, making a prognosis so that you can treat accordingly. And this is where I really learned this and took it to heart from John Coyce's program of understanding where your points of failure are, identifying them in those patients, and correcting them. I read something very interesting a while ago. It said, you ask the dentists, when do your restorations start to fail? And you saw a wide variety of answers. And the ultimate answer is our restorations start to fail the minute we put them in.
Right.
Because
it's time delay.
Patients will say, Doc, is this going to last me forever? And my tongue-in-cheek answer is, what Mother Nature gave you didn't last forever. What makes you think what I can do today is better than what Mother Nature gave you?
I got a really good answer for you. The next one, you can just say, as soon as you are born, you start to deteriorate. So
we start to decay.
That's it. That's it.
So,
Yep.
Dr. Marangos,
Yep.
so this question is for both you and James. So, like, for example, I'm a general dentist. I want to get into this. Like, what's the next step for me as a general dentist? Am I enrolling in Dentist4? Like, how does that? I'm assuming these slides that you're showing us are from Dentist4. Is that correct? Was that part of it?
It's out of his brain. But anyways,
okay.
Yeah, let's Dentist4. So there's a course next week that has some open slots for if you want to stream it live.
Ooh, live stream.
I know that James and David were talking about doing some sort of special deal for.
Yeah, before we get to that, though,
Yeah.
Dennis, I think a good question what Tyler was alluding to is how do you see the general dentist in their journey? Like you were talking about the 7-year itch, that kind of you went into. What is the best timing for a general dentist to get involved in this course and journey of treatment offering to patients? Because I remember you talk about the 7-year itch in dentistry with dentists.
And actually, that is David he's got his toes in the sand somewhere. He sent me that question. So, is it a veteran dentist? Is it too late? Or like, when are you too late to become a Jedi, essentially?
A Jedi. Yeah.
It's interesting. You're never too late, and you're never early enough, because the longer you practice, the more common things we see, the modes of failure of our dentistry. There's a lot of dentistry out there that I call it reduodontics. If you've been practicing long enough, you're redoing somebody's dentistry. Dentists, though, are very, very unique in their vision. They are very particular they're very quick to redo somebody else's dentistry, but very slow to redo their own previous dentistry. So once you start to see these modes of failure in your practice, you get frustrated, and you don't have a system to help get you better. So if you're out of school 5, 6, 7 years, you need to start your journey. This Dentist4 is a starting point, and this will open up your eyes to so many other parts of dentistry that are out there that it's just going to blow your mind. You're going to say, well, how do I find the time to learn all this? Well, you have to make the time. That's the unfortunate thing.
Yeah,
that's an investment.
It's an investment. Edmund's program in TMD and sleep. It's the initial. It's the foundation, because the minute you start helping patients get out of pain, and the minute you start getting them to sleep, you have now got a patient for life. They will do anything you want them to do because you've already shown them what you can do to make their life better. So now you have to learn. The best way to learn other things is hands-on courses. They're hard to find, but they are the most valuable. Our 2-day program that we have we call it the Phase 2, but I like to rename it as your first step to changing from a single tooth dentist to a complete care dentist. That is your first step. And then from that point on, I will help guide you into where you need to go to learn what you need to learn at that point. So it's never too late. It's never early enough. And the minute you start doing a single case, like my evolution was from single tooth to quadrants. And then once you've got quadrants done, then you're like, huh, you know what? Let's try an arch. And then before you knew it, it goes from one arch to full arches, and you develop your own system. And it's the most rewarding thing in dentistry to be able to accomplish that, to help somebody. And I'll tell you, the one thing I found most encouraging is when a patient comes in and after a month, 4 weeks, 6 weeks, 2 weeks, they say, you know what, doc, I haven't had pain, a headache, neck pain, anything since you started your treatment. Think back on some of your cases where you've done a beautiful set of veneers and the patient comes back and they say, doc, I don't like the distal incisal line angle of tooth number 1, 2. And you're sitting there, you're going, oh my God, you came in, your teeth look like a dog's breakfast. I made you look beautiful, but you're worried about the distal incisal line angle? Oh my God. But a patient that can't sleep, they will hug you till there's no end because you just changed their life. And again, another catchphrase to sell courses is, are you too busy saving teeth and you don't have enough time to save lives? Sleep apnea treatment, TMD treatment, can save a lot of people's lives, especially when you get these kids.
Let's go over those numbers too, like the percentage of patients that are existing in your practice that need your help silently.
Well, generally in a general practice, you have about 40% of the patients in your practice. So the original study was by a fellow named Lewandowski. And he identified that 33% of men and 7% of women in a general dental practice have a sleep disordered breathing problem. Most of them also have a superimposed TM joint problem. They just don't know it.
Right.
So when you're treating one, you're actually treating them both, but you need to know both in order to handle that situation. So that's where Edmund's course comes in beautifully, the part 1 on the TMD, and then I kind of combine that for the general dentist.
And you mentioned education is an investment, and I think about the business of dentistry, like we mentioned earlier, about the return on investment not only being financial, but when you talk about saving lives, that's an ROI on a completely different level.
Let's not worry about dollars and cents at that point.
Exactly. And further to that, though, in each of the courses, Edmund, Liam's program, and Dennis's, both of them talk about solid business models to incorporate the treatments into the practice.
Yeah.
It's not, so that's part of the curriculum.
And I mean, I've been lucky enough to sit in on both phase 1 and phase 2, and I'll never forget Dr. Sipra Gohal.
Yeah.
And Dr. Marangos just like blowing her mind, like helping her discover that she was a candidate,
Yeah, she needed her bite needed help.
She needed.
Oh, really? She needed it herself.
She kind of like she was like, it was like, wow.
I spoke to her the other day.
It blew, like she's a lovely human being. But just to
Such a lovely
see
dentist. Yeah.
the light bulb go off in her mind, and the opportunity that all these folks, every practitioner can uncover, like utilizing this knowledge in practice is.
And one of the things that we explain to a lot of general dentists that have this fear of maybe engaging in treatment with some TMD patients is we always encourage them. There's always a percentage, there's always that 80% or that are more straightforward to treat. Mm-hmm. And then there's maybe that 20% where you just think they list off every symptom that could possibly be happening to them. Mm-hmm. And those are the patients who we encourage them, just refer those to, doctors like Dennis or mm-hmm. Edmund or some other AACP type of doctor in your area, because you want to, in the flow of your practice, deal with, say, the more generalized TMD patient.
To
But
start out with, yeah.
also, like,
You
getting
don't have
into
to tackle every patient.
right, getting into this philosophy, you'll also have like Ocean Ceramics. You and David and Tyrell are on the phone
Huge resource. Yeah.
all day supporting these folks through this too.
We help doctors and patients all the time.
Right.
One of my favorite stories I love to tell is a good friend of mine that I coached hockey with. We made him a deprogrammer with a ramp.
Not Brad Marchand, right?
No. I have made appliances for a Boston Bruin though, and I have a testimony from him.
It's true, actually.
It's true. I got it on my phone.
Got it. Yeah.
And he actually texted me out of the blue because he's a local, grew up locally here, and I know the family. But anyhow, he texted me out of the blue once and says, "James, I've never slept so well in my life."
That's
and
amazing.
A pro hockey player. And it's like, well, tell all your friends, and Brad and Bergie and all those guys. But anyhow, this friend of mine that I coached hockey with, we made him a deprogrammer with a ramp because I slept next to him on a retreat, hockey retreat, and he snored like a horse in a barn in a box. I mean, he woke me up in the middle of the night.
I'm trying to picture
It
that.
was out of control.
Visual.
And he says, yeah, Mel, she complains about me snoring all the time.
Right.
I says, dude, I think we can help you. So anyhow, we got the impressions, we got the bite, and I made him an appliance. His wife literally came up to me at practice a couple weeks later and says, "You literally saved my marriage."
Wow.
We can now sleep in the same room and the same bed together. She literally gave me a hug. I said, "Well, I just made him a specialized night guard."
Not to mention probably saved his life.
Yeah.
Also that.
So anyhow, we've had several of those stories. There's, we just help people bounce off the rails and go in the right direction. But it all begins with investing in some education.
Yeah.
Yep.
Okay.
And Dr. Marangos, how does it feel when someone comes and hugs you and tells you that you changed their lives?
It's the best feeling. When they say that my child is no longer considered ADHD. All you did was identify a sleep problem because they wanted to put Junior on Ritalin or something. Right. But that wasn't the problem. The problem was that your child couldn't breathe. So the minute that we corrected that with whatever the appropriate, like, that is a very common scenario when parents come in and say, my kid is a different kid because of what you identified. That to me is worth more, because what we just did was we saved a child from becoming a sick adult. Mm-hmm. Okay. Yeah. And you change their growth and development at that time by doing some really early modifications in their life that can make a difference. But we help adults all the time. And that divorce thing, I've got a couple of patients that call me the best divorce counselor around when you make these sleep appliances. It's like, okay, all right.
I'll take that title.
It was either that or the pillow over the head, right?
Yeah. And then you got to cash in the life insurance after that.
And then it gets a little dark and tricky there.
But what a great story, though. That's it. It's so heartwarming to hear those stories. I know we're going to wrap up here in a few minutes, but or very quickly here. But one last question for you, Dr. Marangos: how do you view the future of dentistry?
It's bright. It's very, very bright. As long as dentists are willing to learn what's needed to make it that way, because dentistry is a very stressful profession. The young dentists coming out now, I think in many cases are brighter than we were when we were in dental school. They do lack confidence. They need guidance. They need mentors. And the ones that are asking for help, they're the ones that are going to just blow it out of the water. So dentistry is one of the brightest professions. I think it was a New York Times article I read a couple of weeks ago that dentistry is in one of the top 10 professions worldwide for future.
Really?
Because people are going to have teeth. When we were in dental school, we were told 1986. I'll never forget it. You guys are going to be out of business. 15 years. There's not going to be any decay. There's going to be no decay. You got nothing to fix.
I remember
well, the profs that were telling us that, they were single tooth dentists. They were only thinking about fixing the decay problems. Well, I got news for you now. People are living longer. Dental implants have changed that whole idea of I'm going to lose my teeth by the time I'm 40. We unfortunately I'm seeing more decay now than I did when I got out of dental school.
Really?
Our diets stink. Our diets stink.
Yeah. I was just going to say.
Okay, and I don't know how many. Yesterday, I think I referred 2 patients for diet management for their sleep apnea. It's something that I have a team of people that I work with that help, because our diets stink for sleep apnea.
Yeah.
I mean, obesity is off the charts. Pediatric obesity, adult obesity, heart disease.
Sugar.
We can manage all of that and help people with the sleep apnea part. And then you got the sugar, the acidic drinks. You've got all of these other things that play a role. So, young dentists today actually have more on their plate than I think we did when we started, because
more options to offer.
And more and more science is coming out, linking oral health into the health of the body.
Well, and we talk about. Sorry, go ahead.
Dentistry right now is these young graduating dentists have a wonderful opportunity if they're willing to take what's out there and take it for a ride. They're going to have a great career.
And Dr. Marangos, Dentist on Demand is a dental growth platform, and I love how this all ties in, because if you could plug into Chat GTB how a dentist can grow their practice, one of the top things that comes out, and this is an AI program, it's going to give Google a run for their money, is expanding their scope of practice.
There you go.
So if here we have the lab, we have the clinician, we have the marketing, the growth platform, we're all kind of coming together on this. Hey, you know what? Stop going after Google to get new patients. Stop trying to bring new patients into your practice. Let's focus on what's in the practice and expanding your offering.
Yeah.
And that all ties us all together. So
shoot fish in a barrel.
Shoot fish in a barrel.
Yeah, I mean, the opportunity exists already. Just go after it.
And that's how the three of us are all connected today. So super pumped having you on the show, and it's been really eye-opening listening to you talk today.
This was a lot of fun.
Yeah.
We just want to talk about
I like got ahead of everybody. And also, Dennis, I was supposed to ask you, were you the smart kid in class, or were you the dumb kid?
I just had something nice and poignant. You went.
I actually gave him that question.
I did. Yeah, I was supposed to ask that in the beginning, but here it is at the end.
Yeah.
I couldn't have been any more middle of the road than anybody else.
Hey, that's a good place to be.
It was, you know what? I had more fun in dental school. When I got into my residency program, the head of the program said, we took a chance on you. I go, what do you mean you took a chance?
Wow.
On me? Okay. What do you mean? Wow. And he goes, you didn't have the top marks in the class, which everybody, usually that's how you got a residency. But we thought you would bring something different to the table and help balance out the other personalities. And I'll never forget it when he told me, he said, but you turned out to be one of the best residents we've had.
Awesome.
And I thought, wow, that's pretty cool. That's pretty cool.
There you go, James.
Yeah, middle of the road. Yeah, middle of the road. Yeah, thanks for that.
Okay, and now we'll kick it to we've got a course coming up.
Can you bring up the slide?
Yeah, I'll bring up the slide.
Okay, Mark's just bringing up the slide. So, this is the promotional element of the show where, for all dentists that want to engage in a journey, learning about airway, muscle health, jaw joint position, and then treating the teeth, on February 3rd and the 4th, we are hosting here at Ocean Ceramics. Dr. Edmund Liam will be teaching that course. Focusing mainly on what we call phase 1 treatment, how to reposition the mandible into that healthy position, optimizing airway, jaw joint, muscles, and teeth. Unfortunately, the course is sold out live, but we do have, of course, an infinite amount of positions to log on to for live streaming. And so one unique offer that we're putting forward is that if somebody, so it's $500 to do the live streaming for 16 credits. It's all AGD PACE approved.
16 credits. Wow.
16.
Holy smokes.
So it's $500, and so if you're a Canadian dentist, it's $500 Canadian. If you're a U.S. dentist, it's $500 U.S. But here's the big benefit that we're throwing forward: if a dentist would like to join as a new member to the American Academy of not cosmetic, craniofacial pain.
Craniofacial.
And that's the organization that has mentored Edmund and Dennis over many decades. That Dentavore, Ocean Ceramics will sponsor half of your tuition for Dentavore, which is $250 Canadian or US, towards your membership in that organization.
Amazing.
So we just want to sponsor, give somebody a little lift up to start their journey. Because we personally have learned so much through mentors from that organization. Dennis was involved there and still is, and so is Dr. Liam. And that's a great position to start your journey, to learn how to do it right.
Yeah, that's great.
And that's
Great
everything.
kickstart.
We see so many doctors make mistakes, and we just want to be proactive. We still all make mistakes, but we want to be proactive in our educational journey.
Right.
And the support is so critical. And knowing that you're moving into a new area, knowing that they've got you guys, they've got Dr. Marangos, they've got a team around them to ensure that they're going to do it correctly and get through it.
Exactly. And all the contact information, Mark here will be posting that.
Look in the description below.
Yeah.
It'll be there.
And so, and I know since we're wrapping up, I have one thought that I want to share everybody before we wrap up the whole thing. And it comes from, I learned this after watching the movie Patch Adams. And Patch Adams was a very, very out-of-the-box clinician in medical school. And they tried to throw him out of medical school. And so he stood up before all the white-haired board members of the medical board, and he said, "Gentlemen, you can get rid of me, but one thing I want to leave you with is when you treat a disease, you win some, you lose some. But when you treat a person, you always win." And this is a lot of what we're doing with our treatment is we're treating the people to improve their lifestyle. And it's more than just fixing a tooth.
I love it.
Absolutely.
I mean,
well said.
There we go.
Very well said, yes.
And with that being said, we need to do this again. This was a lot of fun.
This is a ton of fun.
Dennis, I
had a
I
great
wish the Vancouver Canucks were
Next time, bring wine, Dennis, and we'll have a little foxier
we can do
podcast.
like a digital cheers or whatnot. All right, that is all for now. We will we'll see you next time.
Dr. Marangos, it was great to have you on. Thank you so much for your time.
Nice
Thank you,
meeting guys.
Dennis.
Thanks a lot. Talk soon.